Good evening and Assalamu alaikum. I'm going to share my screen. স্যার আমার স্লাইড দেখতে পাচ্ছেন?
হ্যাঁ দেখা যাচ্ছে বলো
Today's topic is Remifentanil, game changer in anesthesia. I am Dr. Salahuddin, Registrar in anesthesia and pain medicine in Evercare Hospital. To discuss about Remifentanil, at first we should understand about the structure of Remifentanil. It is a fentanyl derivative and it contains phenylpiperidine moiety. But unlike fentanyl and other derivatives of fentanyl, remifentanil has two ester linkage in its structure. And this ester linkage is rapidly hydrolyzed by non-specific plasma and tissue esterase. And this hydrolysis is not dependent on the plasma cholinesterase. So it is not affected by genetic abnormality of the plasma cholinesterase or anticholinergic drugs. Remifentanil also does not affect any drugs that is broken down by the esterase like esmolol or succinylcholine. If we compare the pharmacokinetics of remifentanil with the other opioids, we can see the lipid solubility of remifentanil is lower than the fentanyl. And volume of distribution of remifentanil is also lower than the fentanyl. The pKa of remifentanil in body, it is close to 7.4. And non-ionized portion of remifentanil is 65%, which is greater than other non-ionized portion of the other opioids. And its clearance is also greater than the other opioids clearance. So why remifentanil has more rapid onset of action than fentanyl when fentanyl has more lipid solubility? It is because the pKa of remifentanil. pKa is 7.1 for remifentanil and fentanyl is 8.4. And for this reason, when it is in the body pH 7.4, the non-ionized portion of remifentanil is 65%, and for fentanyl it is only 9%. And non-ionized portion is more can reach at the effect site more easily than the ionized portion of the drug. Remifentanil, the pharmacokinetics of the remifentanil can be discussed with three compartment model. Its rapid distribution half-life is 1 minute. Its slower distribution half-life, redistribution half-life is 6 minutes, and terminal elimination half-life is 10 to 20 minutes. Now the question is, why remifentanil has rapid offset of action? It is due to rapid hydrolysis by the non-specific esterase and rapid clearance of the remifentanil and small volume of distribution. And when we are transfusing, when you are giving infusion of remifentanil, there is a term of context-sensitive half-life. It is the time of 50% decrease in the central compartment drug concentration when the drug is maintaining a steady state concentration in the central compartment. In case of remifentanil, this context-sensitive half-life, that means to decrease the 50% of central compartment drug concentration, is very low than the other opioids like fentanyl or alfentanil. So this context-sensitive half-life, after 4 hours of infusion, for remifentanil, it is only 3 to 5 minutes. And it does not depend on the duration of infusion. But in case of fentanyl, the context-sensitive half-life after 4 hours of infusion, that is 260 minutes, and it depends on the duration of infusion. Regarding the analgesic potency of remifentanil, in some textbooks, that is called the remifentanil has the twice the analgesic potency than fentanyl. But in many other areas, it is told that both fentanyl and remifentanil has quite similar potency. But the fact is, remifentanil is 100 to 200 times more potent than morphine. It has mu receptor agonist activity, but it also have small activity on the other opioid receptors. If we compare the if we compare between the fentanyl and remifentanil, we can see that when we are giving remifentanil in infusion, at that time the effect site concentration initially rises very rapidly, and then it rises slowly, but it never plateaus. And this is very important because when in case of anesthesia there is need to raise the level of plasma concentration of remifentanil, then we can just raise the plasma concentration of remifentanil by increase the infusion rate. And this 90% of the maximum plasma effect concentration is achieved within 10 to 20 minutes. And after discontinuation, the concentration falls by 90% within 20 minutes. And in case of fentanyl, when we are giving in PCA bolus dose, then there is a concentration stacking phenomena. That is, after giving the second dose, the effect site concentration rises 174% than the previous peak. And maximum 90% concentration in case of fentanyl infusion, it takes more than 2 hours. Where in remifentanil, it is 20 minutes, 10 to 20 minutes. And the decrease of effect site concentration after discontinuation of fentanyl, it takes 6 hours. While in case of remifentanil, it is 20 minutes. Regarding analgesia, remifentanil has rapid onset of analgesia, and the probability of analgesia of 95% is within 5 minutes. And it after discontinuation of the remifentanil, it falls below 50% within 13 minutes. In case of fentanyl, the 50% to raise the 50% probability of analgesia, it takes 2 to 17 minutes. And fentanyl is also a rapid acting analgesic. But after discontinuation of fentanyl, it takes more than 1 hour to decrease the level of 90% of the analgesic effect. Remifentanil has more respiratory depressant effect than fentanyl, and it takes only 6 minutes to reach the 50% probability of respiratory depression. But due to its rapid elimination half-life, remifentanil takes only 9 minutes to decrease the possibility of respiratory depression less than 5%. In case of fentanyl, it has lower possibility of respiratory depression than remifentanil, but the possibility of respiratory depression goes below 5% after 40 minutes of last bolus dose. For remifentanil to maintain the 50% of maximum electroencephalographic effect in various age group, that reveals that in older age group, it requires low plasma concentration, low effect site concentration of remifentanil. For that reason, in case of older age group, that is more than 65 years of age, it requires half the bolus dose of remifentanil and 1/3 of the infusion rate which we can give to the young individual. But in case of newborn, due to both increase of volume of distribution and clearance, the elimination half-life of remifentanil remains unchanged. In case of older age group, there is also takes some longer period of duration for the elimination of remifentanil. For dose adjustment of remifentanil, it is usually correct that to take the ideal body weight to calculate the dose, because the pharmacokinetics of remifentanil is same in case of obese patient and in case of lean patient. But in case of propofol, we are usually use the total body weight. To calculate the ideal body weight, there are lots of equation, but what I found that the easiest equation is the height of the patient in meter square into 22. For the induction of anesthesia, remifentanil should be administered with hypnotic drugs, because these hypnotic drugs helps to prevent the muscle rigidity. Remifentanil can be administered in two ways, whether it can be initially given as bolus or it can be given as an infusion. If an infusion is chosen, then the infusion rate is 0.5 to 1 microgram per kg per minute. And if a bolus is chosen, then the bolus dose is 1 microgram per kg and it should be given in more than 30 seconds. And then the infusion can be started. If the endotracheal intubation is done 8 to 10 minutes after the start of the remifentanil, then the bolus dose is not necessary. And what we see in our practice, that in our population, though we don't have any data, but in our population, the infusion works quite well. There is a relationship between the infusion rate and plasma concentration. As we are not using any target controlled infusion, in case of infusion, we are just it is just helpful to remember that the plasma concentration is very important for the pharmacokinetics of these IV agents. That 0.1 microgram per kg per minute of remifentanil infusion creates a plasma concentration of 2 to 2.5 nanogram per ml. And if we increase the infusion rate by 0.1 microgram per kg per minute, then the plasma concentration will also increase by 2 to 2.5 nanogram per ml. Because remifentanil has a very rapid equilibration time, so the infusion rate and plasma concentration maintains a good correlation. And in case of laryngoscopy, usually 3.3 nanogram per ml of remifentanil, it blunts the hemodynamic response in 95% of patients who was also given 2 milligram per kg of propofol. And this 3.3 nanogram per ml of remifentanil, it is quite equivalent to 0.1 microgram per kg per minute of infusion of remifentanil. In this study, which was conducted by Maruta, that is published in BMC Anesthesiology in 2016, they compared the bolus dose of remifentanil with the infusion dose of remifentanil in case of induction. And in bolus dose, they gave two bolus, 0.4 microgram per kg and 0.6 microgram per kg, and it maintained a plasma concentration around 3 nanogram per ml. And in case of infusion, they administered 0.3 microgram per kg per minute infusion for 5 minutes, then 0.1 microgram per kg per minute of infusion, and it also maintained a plasma concentration of around 3 nanogram per ml. And they concluded that the hemodynamic response during both bolus dose and infusion, there is no quite difference. But in our practice, which we are observing that if we give the bolus dose, then we are facing some hemodynamic instability, whether it is bradycardia or hypotension. It is because most of the patients in our setting, they are dehydrated or geriatric patient. So infusion, induction of anesthesia with remifentanil with infusion, it is a better choice for us. For the maintenance of anesthesia, remifentanil infusion rate maintains a range that is 0.05 to 2 microgram per kg per minute. And if we give the volatile agent, remifentanil usually reduces the MAC of volatile agent, and in case of isoflurane, it usually 0.5 MAC is quite enough for the maintenance of anesthesia. And in case of propofol, then the dose of propofol is also reduced. So this is the rate of infusion for the remifentanil. This infusion solution is 20 microgram per ml. That is, we have remifentanil with 1 milligram and 2 milligram. So if we take 2 milligram of remifentanil, that is 20 microgram, and if we mix this remifentanil with 100 ml in the burette set, that is 20 microgram per ml. I am saying this burette because in many areas there is no syringe pump. So that is 20 microgram per ml of remifentanil. And if we give the lowest dose, that is 0.05 microgram per kg per minute, and if our patient is 60 kg, that is 9 ml per hour, that means 9 microdrop per minute. I am explaining this in next slide, that this chart is not necessary to be memorized, but we should memorize one equation, that is ml per hour is dose of the drug, then ideal body weight into 60. So dose of the drug times ideal body weight times 60 divided by drug concentration. So if we take if you take the drug with 40 microgram per ml in a solution, and if we decide that we are going to our infusion rate is going to be 0.05 microgram per kg per minute in 60 kg patient, that is 0.05 into 60, that is ideal body weight of the patient, into 60, this 60, and divided by 40 microgram per ml, and the result is 13.5 ml per hour, and 1 ml equal to 60 microdrops. So this 13.5 ml per hour equal to 13.5 microdrops per minute. So it is not necessary to memorize that table, but we should remember this equation. And how to prepare this solution? The solution can be prepared with sterile water, 5% dextrose or normal saline. And this solution is stable in room temperature for 24 hours. And after 24 hours, it must be discarded. But if the solution is prepared with Ringer's lactate, then it is stable for 4 hours only at room temperature. As I have told that remifentanil has MAC reducing capacity, and most of the opioids has MAC reducing capacity. And I'm talking about MAC bar here, that is um, um, reducing the effect of sympathetic adrenergic response. And in this study, they studied about the effect of pneumoperitoneum and the MAC reducing capacity of remifentanil. That is at 2 nanogram per ml. This 2 nanogram per ml equivalent to 0.1 microgram per kg per minute, less than 0.1 microgram per kg per minute, which is the usual dose. And it causes, here the sevoflurane 1.6% is sufficient for the desired result, where when we are not giving remifentanil, sevoflurane needs MAC equivalent to 4.6%. But in case of sedation during regional anesthesia, in this study, they recognized that remifentanil is not effective for sedation in case of regional anesthesia because in this scenario, propofol is a better agent for the sedation. Though remifentanil has a sedative effect and it is effective in other area, but in case of regional anesthesia, when we are blocking all the afferent activity from the peripheral region, at that point, remifentanil is not quite effective. But in case of liver analgesia, remifentanil is recognized that it is quite effective in first stage of labor, and it causes a satisfactory pain relief in first stage of labor, but it is not quite adequate in case of second stage of labor. And most of the patient in second stage of labor, and they wanted epidural with remifentanil. And for the labor analgesia, the dose of remifentanil is it is usually bolus dose, and it is with patient-controlled analgesia with no background infusion. That means no continuous infusion, because in labor analgesia, it often causes sedation, more profound sedation and respiratory depression. And there are some events of mortality with respiratory depression due to remifentanil in labor analgesia. So there are protocols in labor analgesia with remifentanil. I'm going to discuss about those protocols later, but the bolus dose of remifentanil here is 0.2 to 0.5 microgram per kg, and the lockout time is 2 minutes. But it is very appreciable that the Apgar scoring and fetal cord pH is satisfactory, and neonatal respiratory depression with remifentanil is not very much a dangerous issue, because it has a quite rapid elimination half-life also in case of neonates. But the maternal desaturation is a very alarming issue. And in a Cochrane review in 2016, it was published, and 20 randomized controlled trial on 3,569 patients. And there is a very low quality evidence to make any kind of comment for the remifentanil or against the remifentanil. And they recommended that more studies required to give any kind of comment. So when remifentanil patient controlled analgesia can be used in case of labor analgesia, if there is any kind of coagulopathy or thrombocytopenia or patient in anticoagulant, if there is any spine surgery or anatomical deformity of the lumbar spine, if there is a neurological disease like demyelination, and if there is morbid obesity or when epidural is quite difficult. But in case of morbid obesity, the probability of respiratory depression is same like a normal weight pregnant patient, but there is quite careful vigilance is needed. So there are a lots of recommendation regarding remifentanil patient controlled analgesia in labor. That is, a patient must should know about the side effects of remifentanil, that is pruritus, nausea, or desaturation, and it is not recommended if the saturation is less than 95%. And a separate dedicated IV channel must be used, and no other drugs should be given in that channel. And no other opioids should be used at that time. And the patient should always be monitored with pulse oximeter, and oxygen should be administered at least with nasal cannula, and one-to-one caring is a must here. And there are some maternal instructions should be given before administration of remifentanil patient controlled labor analgesia. That is, the patient should press the handset button when there is any kind of sign of labor contraction. And she should not press the button between the labor contraction, because it takes around 1 minute of time for remifentanil for the peak effect. So when she's pressing the button when there is a labor contraction, then remifentanil will give the analgesia in the next labor contraction. And it should be told to the patient that the button should be pressed by herself, not doctor, nurse, or her relatives. Remifentanil is well accepted in case of endoscopy and ERCP. And in this study, they compared ketamine, remifentanil with propofol, that is low dose remifentanil versus propofol and remifentanil. And in both group, they chose propofol 1 milligram per kg per hour, and in only remifentanil group, they gave 0.2 microgram per kg per minute, and where there is ketamine, that 5 microgram per kg per minute, they chose 0.1 microgram per kg per minute, that is low dose remifentanil. And they observed that when there is ketamine with remifentanil and propofol, the oxygen saturation, that is respiratory depression, is quite low. But in case of this 0.25 microgram per kg per minute of remifentanil, there is respiratory depression. So they recommended that remifentanil should be used in low dose in case of ERCP. And ketamine is a player here. In case of awake fiber optic intubation, remifentanil is a very popular choice, but there is no significant difference between remifentanil and dexmedetomidine. In this study, they compared between remifentanil and dexmedetomidine in awake fiber optic intubation, and in case of remifentanil group, this is the scoring of coughing during intubation 1, 2, 3, 4. The scale of 4, remifentanil that is 1 and dexmedetomidine that is 3, that is not quite statistically significant. And in case of movement, remifentanil there is 2 and dexmedetomidine that is 3. It is also not significant, statistically significant. So in awake fiber optic intubation, the dose of remifentanil it can be given as bolus plus infusion or only infusion, and the recommended dose is 0.075 microgram per kg per minute. And in our institution, we usually use lower dose than this, that is 0.05 microgram per kg per minute. In postoperative period, remifentanil can be used for analgesia if long-acting analgesic is not established prior to the end of the surgery. And in this case, if long-acting analgesic is not established, analgesia is not established, because morphine, it usually takes 10 to 15 minutes for its analgesic effect. And if morphine is not given in this duration of period, so at that time, remifentanil can be continued for the maintaining of analgesia for the immediate postoperative period, because there are some side effects of abrupt withdrawal of remifentanil, and I will discuss it later. If the patient is on a ventilation, like intubated condition, at that period, the infusion rate should be titrated to ensure adequate analgesia. If the patient is spontaneously breathing patient, in that case, the remifentanil dose should be titrated, and the limit of titration is also there is a limit. It should not be titrated in abruptly. The limit is 0.025 microgram per kg per minute every 5 minutes, because remifentanil has a propensity to make tolerance and hyperalgesia if there is abrupt cessation of remifentanil, because when there was remifentanil, patient, the level of analgesic was quite high. And when there is no remifentanil, usually it takes 15 minutes to withdraw all the analgesic effects. So at that moment, if there is no analgesia, patient will feel a high level of pain. So the reduction of dose should be incremental. And in postoperative area, remifentanil can only be administered if there is if the postoperative area is fully equipped with all the monitoring devices, and there is support of respiratory function and cardiac function, and there is closed supervision. And any kind of bolus dose in postoperative area is not recommended. So a long-acting opioid should be established before discontinuation of remifentanil, that is usually 5 to 10 minutes. And sufficient time should be allowed for the long-acting analgesic to reach the maximum effect. And in the choice of analgesic when we are administering the remifentanil, it should be multimodal analgesia to encompass all the pain pathways. Yes, we are giving opioid, and it could be morphine bolus or patient-controlled analgesia, fentanyl patient-controlled analgesia, or pethidine. In this diagram, you can see that if it is patient-controlled analgesia with morphine, that it it works well because it maintains a stable plasma concentration. But a single dose, when there is a reduced plasma level at that moment, then this kind of scenario, it may cause some side effects of remifentanil that it has, like tolerance and postoperative opioid-induced hyperalgesia. It is best practice if we use remifentanil, we should go for multimodal analgesia for postoperative pain management. As the world is moving very fast, and we are also moving from the use of halothane to isoflurane and sevoflurane. And maybe in our country one day, maybe we will not use nitrous oxide as much we are using now, because nitrous oxide has some side effects, because we cannot use nitrous oxide if the patient has pneumothorax, or it should not be prudent to use nitrous oxide if the patient if there is GIT surgery. In Western country, they are more using target controlled infusion or total intravenous anesthesia. And the indication of remifentanil usually goes with total indications of total intravenous anesthesia. That is, if the patient has any kind of history or risk of malignant hyperthermia, or the patient has the long QT syndrome, or the patient has a history of severe postoperative nausea, vomiting, because there is remifentanil in among all the opioids, remifentanil causes the least amount of nausea or vomiting. In case of ENT surgery or thoracic surgery, because nitrous oxide may cause the pulmonary vasoconstriction, and ENT surgery, specifically the middle ear surgery. And if there is any kind of difficult intubation or extubation scenario, the remifentanil has a very rapid onset and offset of action. In neurosurgery, specifically when the neurophysiological monitoring is important, or when the rapid when it requires the rapid extubation in the ICU. In case of myasthenia gravis, or when we want to avoid any neuromuscular blocking agent, because if the anesthesia is performed with remifentanil, usually the requirement of what we see, the requirement of neuromuscular blocking agent is very low. It is very effective in case of neuromuscular diseases. And in anesthesia with non-theater environment, or when a patient is transferred from one environment to another environment, or day case surgeries. This is a large study in 3 countries and 21 centers regarding the use of remifentanil in ICU. And all the patients are mechanically ventilated around 12 to 72 hours. And they gave a high dose of remifentanil, one group, and another group they gave fentanyl. And supplemental opioid was administered if the optimal level of sedation is required. And the result is, in case of remifentanil, for the maintaining of optimal level of sedation, they required only very low level of supplemental propofol. And um, they also experience the patients feel very comfortable than propofol with remifentanil, and but they warn that proactive pain management is very important when we are giving remifentanil. Both remifentanil and propofol are well tolerated, and hemodynamically they have same profile in case of ICU patients. But the titrability and short duration of action and reduced requirement of propofol makes remifentanil a very interesting drug for maintaining sedation, analgesia-based sedation in critically ill patients. And in this study, they studied the effect of remifentanil in case of ICU management for the patients with brain injury. And in this study, they also used a high dose of remifentanil in one group, and in another group, they used hypnotic-based sedation. And when in remifentanil, the level of hypotension, there is 14% hypotension and fentanyl 11% hypotension. And bradycardia, remifentanil is 6% bradycardia, fentanyl 5%. So the profile is not very much similar, remifentanil and fentanyl in case of ICU management, if a hemodynamic profile. And the advantage is the awaking of the patient for the assessment for the neurological function. The time requirement for the awaking of the patient for the neurological function is low, and there is a shorter time for the extubation in case of remifentanil than hypnotic based regime. And there is no difference between pain and sedation score. In case of renal failure patients, the remifentanil kinetics is not altered because its pharmacokinetics does not depend on the function of the kidney. But one metabolite that is remifentanil acid, its clearance is decreased in case of end-stage renal disease. And the concentration of remifentanil acid is more than 100-fold than remifentanil in case of moderate or to severe renal failure. But the interesting thing is the potency of remifentanil acid is very low than remifentanil. For this reason, the pharmacodynamic effect of remifentanil is not correlated to the concentration of remifentanil acid. One problem with not only remifentanil, but also all the opioids, that is serotonin syndrome, that is related to all the drugs that increase the serotonin level at the at the neuronal end area, that is a monoamine oxidase inhibitor or serotonin reuptake inhibitors or the 5-HT3 inhibitors. But in this study, the duration was 2 years, and it was conducted in 4,534 patients. Both are treated with fentanyl and serotonergic drugs. And there is a specific criteria for the diagnosis of the serotonin syndrome that is called Hunter's decision rules. And they only found that 4 patients that suffered the serotonin syndrome. And this Hunter's decision, that spontaneous clonus, a patient with serotonin syndrome, these are the clinical features like spontaneous clonus or inducible clonus with agitation or diaphoresis, or ocular clonus, or tremor or hyperreflexia, or hypertonia or temperature above 100.4 degree Fahrenheit. In previous studies, they revealed that remifentanil does not produce any opioid tolerance. Opioid tolerance is basically this is a crisis, because when a patient when the dose response curve is shifted to the right, so you are giving more opioid to the patient, so this is a crisis. But the newer studies, they are saying that remifentanil has an opioid tolerance effect, and a high dose of remifentanil is related to opioid tolerance effect, and that is around 0.3 microgram per kg per minute. We usually give in our population, what we have experienced, that we usually give 0.05 to 0.2 microgram per kg per minute. So the high dose of remifentanil is quite related to opioid tolerance. And there is also one adverse effect, that is opioid-induced hyperalgesia, that level of pain is increased after discontinuation of remifentanil. And in this case, maybe opioid-induced hyperalgesia can be induced only after 0.1 microgram per kg per minute, and only for infusion for 30 minutes. This can cause opioid-induced hyperalgesia. And remifentanil is the highest reported drug among the opioid that may cause the opioid-induced hyperalgesia. But there are some ways that we can prevent this opioid-induced hyperalgesia, and one of the very important way is gradual withdrawal of remifentanil. What I have said earlier, that we should not do abrupt cessation of remifentanil before extubation. So how we can prevent the opioid-induced hyperalgesia? Intravenous anesthesia with propofol causes the reduction of risk of opioid-induced hyperalgesia. And if we give the NMDA receptor agonist like ketamine or COX inhibitor, or voltage-gated calcium channel modulator or adrenergic receptor modulator, it may prevent the opioid-induced hyperalgesia. And this opioid-induced hyperalgesia is more related with the rapid reduction of the dosing. And there is also one adverse effect, that is chest wall rigidity, and it is usually due to high dose of opioid or rapid administration of opioid. It is not only related to the remifentanil, it can also occur with propofol, with fentanyl, that is high dose and rapid administration. And in case of remifentanil, if a bolus dose is given, that is more than 1 microgram per kg, and it is given, if the high dose is given, and also it may cause chest wall rigidity if a low dose is given with a concurrent IV infusion. And there may be also chest wall rigidity if the bolus dose is given in less than 30 seconds. And there is a way to prevent the chest wall rigidity, that remifentanil should be administered with a hypnotic agent. It may be propofol or it may be thiopental sodium. And infusion of remifentanil is more effective for the prevention of the chest wall rigidity. Thank you.